Yeah,
Okay.
perfect. Thank you. Yeah.
Thank you.
So, just, yeah.
And
So,
So,
please feel free to call me Banika. I'm okay with being called my first
yeah,
name.
yeah, so, Ismam, you can start with the answers. We can add the questions later on with the editing. The, yeah.
Acha,
Uh,
okay.
yeah.
So, do you mind asking actually? Because it gives me a
Sure,
bit,
sure. I'll just,
yeah.
of course. Yeah. Uh, uh, what is it? Uh, is my voice audible? Hello?
Yeah, yeah.
Yes. So, yeah, so thank you so much for removing time from your busy schedule, ma'am. The first question is, in your view, how would you characterize the current policy landscape for dementia in India, and what are the major strengths and weaknesses according to you in our policy?
Okay. So I think firstly to sort of set the context, we know about the prevalence of dementia in India. There's an estimated around 8.8 million people aged living above 60 years living with dementia, a figure that's already exceeding projections from the Dementia India report in 2010. So there's a growing public healthcare challenge. The impact is not just on the person with dementia, but also their families, the healthcare system, and wider economy. The reality in terms of policy landscape is that India currently lacks a dedicated national dementia policy. So, what does that mean in practice? It means that dementia care currently falls broadly under public healthcare and aging programs. So, for example, you have the National Policy for Senior Citizens, you have the NPHCE, the NCD program. So, you have these different healthcare programs for older people under which dementia care currently falls. There isn't a specific policy or program addressing the complexity of dementia. Number two, because there is no sort of national policy level dementia plan, we have a lot of third sector organizations doing some really impactful work at the grassroots level for the risk reduction, diagnosis, care, capacity building, advocating for dementia policies. So you may have heard of ARDSI, for example. There's Dementia India Alliance. There's Hope Asha, it's an NGO. There's Dem Cares. So a lot of really impactful work being done at the ground level. But again, these are third sector organizations, and they're trying to work in collaboration with state levels. So, for example, you have the Karnataka Brain Health Initiative, you have the Kerala State Initiative. Dem Cares launched this program of reaching the unreached in rural populations. So, really interesting work happening. The third thing, as we often know, is that in the absence of a national dementia and formal public health care plan for dementia care in India, caregiving typically falls within the families. And when we say families, due to the gendered nature of caregiving in our country, it often falls on the women, which adds to further stressors and, impacts in different ways. So overall, the care is quite fragmented. The policy landscape is really kind of in a nascent stage, and I'll tell you why I say that. Recently, as you know, I did this research. We published it from with UCL, which was to explore how dementia inclusive are public healthcare policies for older adults in India. And how we did this was that since India doesn't currently have any policies for older people, we identified through a comprehensive data research, we identified 16 public healthcare policies for older people, which are there in India. And then we mapped these onto the 7 action areas of the World Health Organization's Global Dementia Action Plan. And that's in areas like risk reduction, public healthcare priority, awareness, diagnosis, information systems, things like that. So, in terms of the strengths that we found, the good news is that of those 16 policies, which are for only older adults in India, not dementia specific, we found that 6 of those policies, they actually use the word dementia. They mention the word dementia within those policies. For example, the Atal Vayo Abhyudaya Yojana and the NPSC, they mention the word dementia in contexts like, having a dementia-friendly environment, dementia-friendly devices, and things like that. So that's one good news that it's there. There's some sort of a mention. Number two is that out of those 16 policies, 14 of them, which is a good 88%, they contained recommendations relevant to at least one of the World Health Organization's action areas. So that's quite a lot, actually. And of those 16 policies, around 44%, which is almost half, they're aligned with more than half the targets, half the action areas. And what that means is, areas like suggestions for, having regular health checkups, monitoring BP, alcohol consumption, malnutrition, engaging in social lives, community-based active aging, things like that, which we know are risk reduction strategies in dementia. So they're quite relevant to dementia care as well. Then we had around five policies, I think, which talked about how can we have a multifaceted approach for caregiving in India, for caregiving support. So things like family education, capacity building, financial relief for family members, respite provisions, protection of the rights of older people. So all of these can also be extended to dementia care to some extent. So in that way, I'd say it's an optimistic start that we do have some existence, some opportunity of integrating specific evidence-based dementia care policy recommendations within the already existing public healthcare policies in our country, which is a really optimistic start. Something which perhaps we didn't know much of earlier, and I think this research kind of presents that reality to the picture. Um, in terms of weakness, I think one thing which really struck me, and there were several things pointed out in the paper, but one thing which really struck me was in terms of the quality of these policies. So we used a formal checklist system, a guideline checklist system. It's called ICAHE. And we used that to formally rate all the policies that we included. And unfortunately, all the 16 policies were rated as low quality. And what that means is that there was an uncertainty about what was the basis of evidence of the recommendations? How was the evidence collected? How is it prioritized, appraised? Who developed these recommendations and these policies? What is their experience in working with older people and dementia care or just in general older health, older care, public health care? So with these uncertainties, it's difficult for us to know how these recommendations are relevant to the diverse population in India and can be, applied in ways that are evidence-based, that are helpful, that are culturally sensitive and relevant. So I think that's something that's really important to consider in terms of a weakness. And I think there's other research as well, which has found similar results in terms of public healthcare policies in India in other fields also being of low quality. So something for us to consider that when we do move into the stage, hopefully, of integrating dementia care into existing policies, how can we do it in a way that improves the quality of these policies as well? So I think overall, in terms of the landscape and strengths and weaknesses, I hope I sort of clarified that. It seems to be that there is some foothold in policy, keeping in mind that we have existing policies for older people, but nothing specific for dementia. The care lies amongst sort of other areas of the public healthcare system and beyond it. And there's a lot of work that needs to be done.
Yes, it's so true. Yes, ma'am. Like if the all the 16 policies are of low quality, that's a really sad situation which in
Yeah,
which we are in right now.
yeah,
So the
yeah.
next question is, how does the absence of a high quality dementia policy in India impact the marginalized groups like the rural populations, the women caregivers, like you mentioned, that
Mm,
women, the major brunt of caregiving is uh, thrust upon women in our country and those who are facing financial insecurity.
mm.
Yeah, so
Yeah. Yeah, absolutely. So we know from research as well as from general sort of clinical practice and experience that marginalized groups in India, they are disproportionately and uniquely affected by dementia. And let's go beyond just, rural and women and financial insecurity, because in India we have so much intersectionality of the different social positions that we all hold. There's a multiplicity of identities that we all hold. So you would have things like, gender, caste, rural and urban, you have education levels, you have sexuality, you have physical health, mental health, disabilities of different kind, which are visible and invisible. And all of these in different ways, they shape our experience of the world. And in extension, they can shape how we experience dementia and also the kind of care and access to care that we receive. So let's take an example. If we have, let's say, a woman who's from a lower caste living in a rural village in India, and she starts showing signs of dementia, like forgetfulness or, becoming quite aggressive, wandering, etc. Now, the family may not necessarily recognize these as medical symptoms because they have little access to health information and services. Instead, they may think that she's behaving this way on purpose, owing to the patriarchal society that we live in. It might be like, oh, there's a sense of blame put on the woman. It might be, oh, there's an evil spirit, for example, and she's going crazy. There's a mental illness concerned. So these different interpretations coming from a rural background, for example, and not having access to healthcare information can impact how we perceive the dementia symptoms. What can happen then is that, like I said, the woman might get blamed. Also, let's say if there's an added layer of being from a lower caste, then there might be a stigma of the village community perhaps not providing the kind of support that they need as a family. Maybe they might judge them, maybe they might shame them. There may be a fear of discrimination as well. So many different ways in which our different identities, especially coming from marginalized groups, can really impact and shape how we experience dementia and the care that we receive. Um, I was reading this paper recently. It was by the Dem Cares organization, and they talked about how people in villages, um, let's say the mother has dementia, and the children, they have to travel long distances to go and earn money so that they can put food on the plate and have pay their bills, etc. Because that's happening, inevitably the mom is left home alone. She's isolated, she's not getting the care that she receives to maintain her quality of life. So it's not by choice that she's being isolated, it's by economic necessity. That's another example of it. Then you have trans people in India, extremely one of the most marginalized communities in so many different ways, in terms of psychosocial and economic challenges. And what can happen with them is perhaps they might have a lack of social support system around them. They may not be able to afford MRI scans, medication. They may be misgendered by healthcare services. There may be a risk of safety to them. So many different ways, which are completely not the person's fault. It's the healthcare system's accountability, and that can make it so difficult to be able to receive the kind of care and the quality of life and the dignity of care that we all deserve. So I think in many different ways, sort of lack of policies itself, forget high quality, lack of policy itself can have this big gap between the demand of dementia care in India, because it does exist, and how we're able to meet that gap and how we're able to do it in a way that's sensitive to marginalized communities as well. Even in urban areas, I'm sure you'd experience it yourself when people notice symptoms of dementia and their family members, they may not know who to go to. May not know what sense to make of it, which doctor specializes in it. So there's so many gaps in different parts of the different of our country, and that can really impact, yeah, how we experience dementia, and that's how it's provided.
Yes, so from what we understand, ma'am, what you're saying is we need to work on the grassroots for to and awareness. Like it is important to make the people aware in basic normal communication language, not jargon that we use in our
Mm-hmm.
medical books, but basic language which people communicate in, so that they understand the basic differences between a child is not dementia. It is dementia, not forgetfulness. Like it's a
Mm-hmm.
pathology, it's a disorder, and that there are so many different factors in place, like migrant labor, unemployment, which adds on to the stress on the dementia patients,
Yeah.
especially the women in India, in rural India.
Yeah,
Yeah.
yeah, yeah.
So
And I do think along with women, like I said, There's so much variations in the marginalizations of people in our country in different
Of
ways.
course. Yeah.
And everyone deserves a right to live with dignity and to receive the quality of care.
Yeah. So, ma'am, the next question. What, according to you, is the one action area out of the seven action areas identified by the WHO Global Dementia Action Plan, which the Indian government should prioritize on, which will create a difference in the patient's life?
Hmm.
Yeah. So,
Yeah. I was thinking quite hard about this because I was like, well, they're all so important in their own ways. But I think to give a very clear response, clear sort of, yeah, perspective from my side, I think is when we think of dementia in India, it's suffering from a lot of different directions. So there's no policy, it's largely stigmatized, it's misunderstood, lack of research, funding, trained geriatric healthcare professionals. So there's a lot of gaps in different ways. The one area I think which is an urgent need for us to focus on, one of the action areas, is to declare dementia as a public healthcare priority in India. The reason I say that is because when we declare something politically as a public healthcare priority in India, it may raise the necessary political urgency, the commitment needed, and the psychological shift in mind to address the complexity of dementia care in India by aligning it with existing priorities, existing and available resources, and sort of operationalizing a multi-sectorial public healthcare response, which is so important when we're dealing with something as significant as dementia in India. So, what I mean by that is, for example, having camps for dementia screening, having a public healthcare response to training healthcare professionals, funding research, having advertisements by celebrities on the importance of dementia, having movies made representing dementia in its various forms and how help can be accessed, how we can improve the quality of life. There's so much that needs to be done. Making dementia visible politically and socially, I think, is the first step to real ground level change in our minds and in our approach towards tackling dementia efficiently as a country, I think. How we can do that is, for example, policymakers, they can address. So we already have the mention of dementia in some policies, like I had said, from the research that we published. So maybe in those policy papers, we can add a sentence of dementia is a public healthcare priority. And that integration itself can really have a, implication of what we need to do next now. This was done in the Jordanian policies as well a few years ago, and it really makes a difference. We can think about, policymakers can think about how can we identify certain units or ministries within the government, within the, Indian context, who are responsible for data monitoring and for research in dementia care. So I think declaring it can be really helpful as a public healthcare priority. And the thing is that our country has successfully done that before. We have the tools, we have the resources. Let's learn from our own history. I remember when I was very, very young, at that time, there was, polio, which we were tackling as a country. And I think it was declared as a public healthcare emergency in the 1990 something, I can't remember the year. And what happened next? We had political awareness around it. We had advertisements by Amitabh Bachchan talking about how it's important to get those, polio, those, what was that, do boond ke bare mein, right? So different
two
things.
wounds in the kiki. Yeah, yeah.
Yeah,
Yes.
exactly. We had schools and communication. We had schools coming on board with communicating with children and with families of how important it is. We had campaigns, destigmatization, research labs for polio. And what happened next? I think in 2014, India was declared polio free. So, at a national level, it was declared a public healthcare emergency, and we used our resources, our priorities, our sort of sectors together to tackle the problem and to make a huge difference. So I think that is possible for dementia as well. It's very different to healthcare conditions, um, but India has done it before, and I think we can do it again.
So true, ma'am. So true. Yeah. It makes sense when the polio campaign, we could eradicate it because, like, Amitabh Bachchan's that the advertisement, it's in the
Stuck.
mind of each and every Indian. Like
Mm.
everyone knows about it. So yeah,
Yeah.
uh,
Just as
yes.
importantly, it is also a critical part of the medical syllabus when it is relevant for us as well. Like it is one
Mm.
of the most important subjects that we study as medical students. So integrating it into our medical system itself
Mm.
is also an important thing that can be done to sensitize more doctors towards it.
Yeah, yeah, absolutely, absolutely. I think we have a really a lack of healthcare professionals in India who are trained in geriatric healthcare and specifically dementia care, and that
Mm.
itself is one massive gap which needs to be addressed.
Uh, so true, ma'am. So the next question is, what lessons can India learn from other countries' dementia policies, and how can we adapt them? Like we should not just copy them, but adapt them according to our own culture and our research and our resources. Yeah,
I
and
think,
specific. Yeah, so,
go on.
may continue. Yeah, yeah.
I think just because of, in the interest of time, I think this question is kind of covered in things we've already discussed. The only
Sure.
thing I
Yeah.
can add in this is that, if you look at the policies in, let's say, the UK or Australia, it's very data driven. There's data on what the prevalence is, what the numbers are, risk reduction, what are our goals, what's achievable, what's not, how do we collaborate with third sector organizations. There's plans, it's concrete, it's data driven. And I think that really stands out to me from the policies in international kind of like from UK and Australia, for example. And I think in India, that can be one aspect of it which we really need to work on in dementia care, is the data monitoring and having our policies being data driven, so that it can be evidence based. Yeah, it's a very short answer.
So I guess, yeah, this answers the question, that question as well, that why are you collecting data if dementia is a non-curable disease? We need to collect data because it is important.
Yeah, and if we
Yeah.
don't have data, we don't have research. If we don't have research, we can't develop um, evidence-based interventions, care within our country's context. Then we'll be dependent on what's done in other countries, but they may not necessarily be applicable to us. We'll have to adapt them more intuitively. What we need is actually research in our own country that is relevant to our context. So data helps us go towards that. It also helps us advocate for the need for policy, for the need for funding, for the need for resources, training healthcare professionals, respite for caregivers. Data kind of pulls it all together.
Thank you so much, ma'am, for everything, like for the interview, for removing time from your busy schedule. And so sorry for the uh, technological disabilities, which we like. Thank you so much for everything.
Okay, thank you so much for
Thank you
organizing
so much
this.
for
Yeah.
this.
Whenever free, please just share the video through a Google Drive link or something. We'll convert it and do the rest of the things.
Take care. And by when
So
do you think you might be able to share the different videos, etc., just so I have something
okay.
in mind?
We'll just contact with the tech team and just let you
Okay.
know.
Yeah,
Yeah,
just let me
because
know by email.
next week, yeah, so from 2nd to 12th December, everyone is going on the North trip, like the batch trip. So everyone is on vacation. So I don't,
Make sure to get it done as quickly as possible, man.
yeah,
Make
so
sure that.
Okay,
whatever between 12th December and 25th December, we'll just confirm and let you know
take care.
everything.
And send me your
Mhm.
IDs and all the Instagram handles and everything as well. So
Sure, ma'am. The Instagram handle, the LinkedIn handle, everything will just through email, we'll just share it with you.
take care.
Thank
Okay.
you so much, ma'am. Thank you so
Thank you.
much.
All the best to all of you. Well done. Take care.
Thank you.
Bye.